All right, welcome to The Explainer. Today we're breaking down 3 of the trickiest, most common presentations you're going to face on the wards. The patient who fainted, the one who's dizzy, and the one who feels weak. By the time we're done here, you're going to walk away with a solid clinical framework for each and every one.
So here's our game plan. We're going to tackle fainting, dizziness, and weakness, treating each one like a clinical puzzle we're going to solve together. Then we'll pull it all together at the end and look at the core principles that link all of them.
First up, the fainting patient. This one's a classic. And your number one job right out of the gate is to figure out, is this something benign or is this something truly life-threatening?
You've got to get this definition down cold because it's everything. Syncope is, at its core, a blood flow problem. And it's not just any blood flow problem, it's affecting the entire brain all at once. This isn't a seizure, which is an electrical problem, or low blood sugar, which is metabolic. Nope. This is a temporary, global drop in perfusion. If you can remember that, you're already way ahead of the game. Okay, I know this diagram looks a little intimidating, but stick with me. This is basically the body's built-in anti-fainting system. See those little sensors right there in the aortic arch and carotid sinus? Those are the baroreceptors, and they're constantly checking your blood pressure. When they sense a dip, they shoot a signal up to the brainstem. The brainstem then hits the panic button, telling the sympathetic nervous system to kick in, speed up the heart, and squeeze the blood vessels. When someone faints, it's often because there's a glitch somewhere in this exact circuit.
And this slide just lays it all out perfectly. This shows you the 2 patterns you have to distinguish. On the left, with neurally mediated syncope, just look at that. Both the blood pressure and the heart rate take a nosedive together. It's a total system crash. Now compare that to the right for orthostatic hypotension. The blood pressure drops when they stand up, but the heart rate, it just sits there. It doesn't do its job. It fails to ramp up like it's supposed to. Seeing this difference can instantly point you in the right direction. Okay, so this is your mental model. When that patient comes in, you're immediately trying to figure out which of these 3 buckets they fall into. Is this a reflex problem where the wiring got crossed? Is it an autonomic failure where the system just doesn't respond? Or, and this is the one we absolutely cannot miss, is the heart itself the problem? Is there an arrhythmia or some kind of blockage?
All right, let's switch gears to our next patient. And with this one, the words you use and the words the patient uses are everything. You have to be a detective here.
So the first thing you have to do is nail down what your patient actually means by dizzy. Is it that woozy, I might pass out feeling? Because that's really pre-syncope, and it points you back to a blood flow problem. Or is it true vertigo, that unmistakable sensation that the world is spinning or that they are spinning in the world? That one question is your first and maybe most important diagnostic test.
So once you've confirmed it's true vertigo, this table becomes your best friend. This is how you figure out where the problem is. Is it peripheral, out in the inner ear, or is it central, in the brain itself? And honestly, the whole game often comes down to the nystagmus. You know, those little involuntary eye movements. Pay close attention to their eyes. Is the beating horizontal, or is it vertical? That little detail can be the difference between a benign inner ear issue and a much scarier problem, like a stroke. And here's how you can actually clinch the diagnosis for one of the most common causes of vertigo, BBVV, right at the bedside. You're not just watching the patient. You're physically trying to provoke the symptom. You're moving them to see if you can shift those little pesky crystals in the inner ear that are causing all the trouble. If you can trigger their vertigo and you see that classic nystagmus, bam, you've got your diagnosis.
Okay, on to our third and final puzzle, the patient with weakness. Now, here's the big mindset shift for weakness. Your first job isn't to know what it is, it's to know where it is. Localization is king. And to localize, you've got to know the map of the nervous system. Think of these motor tracks as the superhighways that carry the go signal from your brain all the way down to your muscles. The command starts in a motor cortex, travels down these highways through the brainstem and spinal cord. A problem anywhere along this route is going to cause weakness. Our job is to pinpoint where the accident happened.
Now this table, this is like Neurology 101, but it is absolutely fundamental. You're basically asking, is the problem upstream in the brain or spinal cord? That's the upper motor neuron. Or is it downstream in the nerves after they've left the spinal cord? That's the lower motor neuron. And your exam tells you the answer. If you see increased tone and hyperactive reflexes, you're thinking UMN. If you see floppy tone and absent reflexes, you're thinking LMN.
And this is where it all comes together. This flowchart is brilliant because it shows you how your physical exam findings literally build you a roadmap for what to do next. So you ask, where's the weakness? Let's say it's hemiparesis, one whole side of the body. Okay, you follow that branch. Then you check for UMN signs. Yep, they're there. Boom. The map points you right to a central cause in the brain and tells you your next step is probably an MRI. See, your exam directs the entire workup.
So we've gone through 3 really different presentations, right? Fainting, dizziness, weakness. But what's the common thread here? What's the core principle that ties it all together?
It really boils down to this. You don't need to be a walking encyclopedia of rare neurologic diseases. You just need a systematic approach. Number 1, the history is everything. Seriously, just listen. The patient is usually telling you the diagnosis. Number 2, localize before you diagnose. Always ask where before you ask what. Then it's about recognizing patterns and, of course, always making sure you've ruled out the scariest possibilities.
So that leaves us with this final question. When you're faced with all this neurologic uncertainty, what is your single most powerful tool? It's not the scanner, it's not the lab test, it's you. It's taking a careful history and doing a thoughtful physical exam. Those are your superpowers. Never, ever forget that. Thanks for diving in with me.